IL-2 is still the only FDA-approved therapy that has shown long-term remissions, which not quite cure, comes the closest we can claim for cure. There is a lot of information and new information even at this meeting about emerging immunotherapies. At this point, how IL-2 will fit in with those as well as the targeted agents or tyrosine kinase inhibitors or TKIs is unknown. But IL-2 has shown a durable benefit for a subset of patients, and therefore in some combination form it will continue to have a role in treatment of renal as well as melanoma. IL-2 is traditionally be used in the treatment naive setting, the first line setting. That's primarily because it got approved in 1992 as the only FDA approved agent for renal, as well as later, a few years later, for melanoma. So traditionally it has been front line before any other therapies, but now we do see more and more patients who have received a TKI upfront and then come to us for IL-2. And there has been published data, including from our group, which shows that these patients do pretty much the same as those untreated. So in this situation, I would say IL-2's role is 0 prior treatments or 1 prior treatment with TKIs. Absolutely. I think the role of checkpoint inhibitors in IL-2 is overlapping but a little distinct. So there may be patients who do not respond to checkpoint inhibitors who do respond to IL-2 or vice versa. In fact, the most exciting avenue of future trials, including some that are launching or are just launched, is a combination of immunotherapies, including combinations potentially of IL-2 with some of these checkpoint inhibitors. So I don't think that they are exact redundant overlapping modalities, but they would complement each other. IL-2 has not officially or formally been tested in the exact sequence, and that is true for many of these agents because they're coming thick and faster than we can position them along the treatment paradigm. For example, there are now 10 approved, FDA-approved therapies for renal cell, for example. So IL-2 still would hold a role most likely earlier in the disease course, upfront, frontline, or after 1 or 2 therapies. And both with TKIs as well as with newer immunotherapies, eventually it may end up that we treat more and more earlier for these patients with IL-2 as well as most of these immunotherapies that are emerging.